Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to SLP Learning Series, a podcast series presented by SpeechTherapyPD.com. The SLP Learning Series explores various topics of speech-language pathology. Each season dives deeper into a topic with a different host and guests who are leaders in the field. Some topics include stuttering, AAC, sports concussion, teletherapy, ethics, and more. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. Now, come along with us as we look closer into the many topics of speech-language pathology. Welcome to Season 7, Telepractice. It's not just screen time.
Hello, everyone, and welcome to the podcast mini-series Telepractice. It's not just screen time, presented by SpeechTherapyPD.com. Thanks for joining us for this episode, Tele-Assessments in the Clinic Setting. This audio course is offered for 0.1 ASHA CEUs. I'm your host, Corinne Hartunian-Kukeon. I've been a speech-language pathologist for over 2 decades, with 13 years experience in both special education and healthcare settings. Here are the financial and non-financial disclosures. Corinne Hartunian-Kukeon is a sole proprietor who consults on telepractice services and works with professionals on accent modification to enhance their communication skills. She is a regional manager at Parallel Learning. She is also the host of this podcast and receives compensation from SpeechTherapyPD.com. Her non-financial disclosure is that she is the current associate coordinator for ASHA Special Interest Group for Telepractice SIG 18. Roxana Gonzalez receives an honorarium from SpeechTherapyPD.com for this episode, and she is also a full-time employee at SLP Tele. Roxana does not have any relevant non-financial disclosures. And now here's a little bit about our guest today. Roxana Gonzalez, MS CCC-SLP, is a bilingual speech-language pathologist with experience in hospitals and clinic-based settings. Roxana has worked with pediatrics, adolescents, adults, geriatric populations, providing bilingual assessments and treatment services. Prior to pursuing a career in speech pathology, Roxana worked as a certified behavioral health case manager for children and adults with mental health disorders. Additionally, Roxana also has postgraduate training in data science and business analytics. Her diverse background and transferable skills serves her in meeting the everyday needs of clients. She is passionate about the idea of bridging technology, research, and clinical skills in telepractice. Welcome to our show today.
Thank you. Thank you for having me.
Absolutely. So let's start with a little bit about you. Tell us about your journey as an SLP and how you came to doing telepractice.
Definitely. So my journey as an SLP began in 2015. I had obtained a bachelor's degree in psychology from Nova Southeastern University, and I was working as a mental health targeted case manager after that. I worked with children and adults, and if you're familiar with this field, you are basically advocating for underserved populations and linking them to resources in the community, primarily their health needs. So I came across speech-language pathologists and what they do, as many of the kiddos that I served, and some adults as well, they needed this service. And I was able to participate in some sessions and observe their progress and collaborate over time see where they were at. And that's when I decided I love to talk. So this is for me. And I went home. I remember that day, still today, where I researched what a master's degree in speech pathology from Nova, because I had already gone to Nova for my bachelor's, and I saw the requirements, and I'm like, I can spend 2 to 3 years here. And till this day, it's definitely for me. I had various externships and internship experiences, primarily hospital based. I went to Joe DiMaggio Children's Hospital and was mentored by Dr. Tommy Braun from the craniofacial team. There was craniofacial, a very specialized area. After that, I had the opportunity of going to another externship at Memorial West. Memorial West is some shadowing at the NICU there, and then outpatient services for children and adults. And after I felt my skills had gotten stronger, I applied for an internship at the Veterans Hospital. To my knowledge, it was one of the only paid internships, and I really needed to get paid too. So I was just flabbergasted to be accepted and have that opportunity to be an intern there, where I worked under the mentorship of Aquila Johnson at the Miami VA. And I would say these were my first practical experiences as a medical based SLP. I was lucky enough to do MBS and, FEES experience under guidance, of course. But after that, the clinical fellowship opportunity came at a private practice. The hospital asked me to stay the VA, but they wanted to start 8 months later, and I needed the money, Karine. So I definitely looked for a private practice where I can be mentored, and I worked at B&V for my 10 months there as a clinical fellow, where I saw children and adolescents all the way up to the age of 18. A lot of medically fragile as well became my specialty there. And after that, I was looking for a telepractice company where I can work. And since I hadn't acquired any school-based experience, that's where SLP Tele came up, and I'm still there.
Awesome. So you are 100% medical speech pathologist with experience in telepractice as well as in person. Amazing. So we're really fortunate to have you on the podcast today. So today our learner outcomes are as follows. By the end of the course, participants will be able to 1, summarize current research on tele-assessments, 2, discuss tools that enable both standardized and informal telehealth assessments, 3, identify the benefits and challenges of virtual assessments. And we are going to try to focus on the clinic-based aspect, but certainly we'll try to cover some differences between the schools as well. Now let's go ahead and dive into the body of this podcast here. What is the role of tele-assessments in the field of speech and language pathology?
Yes, so telehealth is the use of telecommunication technology, and you use it to provide health services to people that are located at some distance from the provider. In this case, the SLP, and the client is really meeting with you at a distance to access your services. You are a qualified specialist, and they are seeking to have that consult. So that's really the purpose of the telehealth and being able to provide services through this mean. Now, I want to dive into the benefits of that. In telehealth, you are able to improve access to needed health services, and you are amongst one of the qualified specialists that individuals seek to connect with. Now, this is typically done in a video conferencing modality, what we call telehealth, telepractice, and all those other synonyms. It's very convenient. Some clients will tell you that they really enjoy just coming to their session from the comfort of their home. So decreased travel time, less time in traffic. If you're late because you forgot your session, you can just hop on. It's never too late to get something done. And just eliminates barriers. So weather related, geography. So I'm bilingual, and geography is important because I'm able to reach clients that need bilingual therapists, or Spanish speaking is my other language, my primary language, really, I like to call that. And even in the pandemic, right, where we couldn't meet face to face, and there was just a lot of mandates per state about stay home or not. In Florida, there was a little bit of more loose in that sense, but other states, I know, like in California, you were asked to stay home for most of the time. And just family centered, the opportunity to collaborate on the evaluation process, right? And be able to develop intervention goals with parent feedback in a natural environment. This is how they are at their home. This is how they present. This is the family dynamics. They're live. You're able to observe, ask questions, that reflective listening and active listening, right? Brainstorm with them and plan about what you would like your therapy sessions to look like if you have a need, and that's identified through tele-assessment.
And that's definitely the beauty of the clinic based, where you have that option to do it from home, as opposed to students that go to a brick and mortar building and that you're doing that assessment in their school environment. So that's
Right.
wonderful. So yeah, let's go ahead and talk about the research. What does the research say about teleassessments for speech pathology?
Yes, there is research out there, and I'm still learning more and more each day as I navigate and go into this. So just know research helps to guide your clinical decision making. It is a tool that we have as clinicians to be able to have this information, access it, and put it to use in the work that we do. The use of telepractice is where you can basically perform individualized assessments, and practitioners were doing some of this before COVID-19, like LSVT, if you're familiar with the protocol for get louder and be able to, for the stroke and Parkinson's patients, there's more research, prior to COVID. Now, it really came where the researchers found that it is not anymore an option. The mandate was on, and this was the only option for many, many people. And that's when I feel like research accelerated in that area. And more people started looking at, well, we need to guide clinicians about what is valid, what is valid, because most of these standardized instruments, they had been validated in in-person administrations, but not necessarily over telepractice. So clinicians wanted to do the best for their clients. I think everyone has the best interest of the client at heart. And it was just a matter of, can we use it through this medium? What is the best way to administer it through this medium, and best practice guidelines? And how do we ensure the client does continue to get quality care? And so, with all the uncertainty, I feel like publishers started to look at that, as well as researchers. And one of the biggest problems that evaluators faced was, how is it that the presentation can mimic in-person administration as much as possible? So, and ensure that the results can still be compared to the norms that there are, without overgeneralizing or making significant modifications that throw off what your instrument is really intending to measure, right? So there were examples about what tests started being validated. And I do have something to share with you. Let me know if you'd like me to go and dive into that.
Yeah, absolutely.
Okay. So I have shared just the general common issues that kind of stirred the thought of how should we do this, right? And one of the biggest issues was overgeneralization. So if you have an investigation or a research study where one particular test is chosen by the researchers and the research want to see if it is valid to be used over telepractice. And this is done usually picking out one standardized instrument and matching individuals. So one of those instruments that was studied was the test of integrative language and literacy skills that many SLPs might be familiar with. And so if you are familiar with this test, you know that it was administered in person and norms were obtained for the population of 6 to 18 years of age. So you are administering maybe about 15 subtests, if I remember correctly, it has. And then you also get your core scores that create this profile of strength and weaknesses for the client in literacy and language skills. So in the traditional administration of it, you are the examiner, you have a hard copy of the stimulus book in front of you. It's like a spiral bound easel for many of the tests, not just this one. And you present it to your client for administration. Now, in Teletills, the research team had a close replica of that book, but they used PowerPoint software and with screen sharing displayed it in a manner that mirrored the stimulus book. And for the non-word repetition portion, they embedded audio files into it. So they used that technology and they were able to mimic as close as possible, right? The real world experience of having a client right in front of you, but just the administration through screen sharing. And what they found was, well, it's a bit of a long test. So let's work 60 to 90-minute duration. And let's work with maybe 2 sessions at most if it needs to be broken into parts. So Nelson and their team that's assessed these 51 children and adolescents, they decided to divide it into age groups. So the younger ones, 6 to 7-year-olds, the middle group was like 8 to 11-year-old, and the older group, 12 to 18 years old. And the study found that there's preliminary evidence suggesting that the Teletills results can be equivalent to traditional test, the traditional in-person administration format, and it supports the validity of administering that test through Tele-Assessment, as long as the guidelines are followed. And the way that they learned about this is they sent an in-person rater to the client's house. So each client that was part of this study had an in-person rater listening to their responses and scoring it. And at the same time, there was a telehealth practitioner administering this exam. And then they compared agreement of results. And the agreement rate was high at a 96.1%, which is pretty impressive if you look at it in terms of number. 49 out of 51 cases agreed on the outcome of the battery as it examined, or it was looking for that. Whether
Yeah,
they
that
had
is
language,
pretty
it's pretty
impressive.
high.
Yeah.
Then statistics was put into it, and the Cohen's kappa statistic, it showed 0.87, which is an excellent level of agreement. So that's pretty.
Yeah. And I would like to kind of clarify for those of us that took statistics a really long time ago. What is the difference between assessments that have been normed on certain populations, for example, norm referenced, and the research? What does, the research about no statistical difference, if we hear those terms used, no statistical difference with in-person versus telepractice administration? If you could just briefly explain that to us, that'd be amazing. Thank you.
And as you really consume research, you'll see that it's always a term that's well defined. And this helps us as clinicians kind of navigate that as well. If you have a normative sample, you have chosen a group that you basically want to assess. You want to look at that group. But you and I, if we were part of that group, we're still part of a larger population. So when norms are used, they determine what is typical or normal behavior for that given population. But just know that the normative sample, or what we refer to the norms, were obtained by accounting for what do you want to study? Maybe what ages or what background, ethnicity, and if it's supposed to be diverse and account for cultural differences, then you're maybe studying a diverse group. But we are all part of that larger population. So I think the biggest takeaway is a norm is a sample from the normative sample is the sample from which norms are obtained, and it consists of a group of individuals sampled from a larger population. And statistical difference is different in the sense that it refers to whether the observed results are because of chance or some other factor of interest, what is known as your alternative hypothesis. If you have know a little bit about statistics, your null hypothesis is something that was occurred only by chance and not because of the claim that you made. So no statistical difference cannot be used to support a conclusion of there was no difference in these groups. Like if we go back to the study I mentioned that studied the TILs, it does not mean that there was absolutely no difference or that the test was even can say that it was equivalent. But what it really means is that you are expected to be able to administer it with some level that it's a similar way to know that the results have a lot of agreement between the in-person raters and the rater that is doing it on telehealth, as long as the best practice guidelines are followed. So does that help?
Yeah, absolutely. And one, I think, important question, because as clinicians, we often hear there are times when we should not report standardized scores. And maybe if you can comment a little bit about when should we not report standardized scores, or when should we report them with some qualifying statements? That would be amazing.
Right.
Talk about that.
Yeah, I definitely, when I started doing telehealth, I had this same question. Can I report this scores? And if I do, how do I let the person reading my report know that it was even done through this modality? And now a little bit more into it, I can say you can report it as long as these guidelines are following. We are going to talk a little bit more about what those guidelines are, but the main takeaway is yes. And if you're searching for tools to aid your clinical decision making for identifying language disorders or literacy or any other areas that we examine, just make sure that you make informed decisions about what instruments have been validated that exist. And these instruments have best practice guidelines on how to use them and how they should be administered. Even if they deviate from the traditional in-person administration method that they were normed on or that we have norms from. So clinicians who deliver telepractice services, you must possess specialized knowledge and skills in selecting these assessments and interventions, right, that are appropriate and valid when administered remotely. And you can see in the ASHA practice portal, they really make a statement on how these instruments should be selected, and they kind of point you in the right direction, but you do have to go into the instruments that are validated and read a little bit more in depth about what the recommendations are. So some publishers of standardized assessments have developed guidelines about the administration of tests via telepractice, and others have compared the validity of in-person and remote assessment protocols. So while not everyone has gone the research route, at least there's some guidelines about if you're going to use them. The publisher does tell you how they would like you to administer it to mimic those in person. But of course, I, having a research background, do like to use the ones that have been tested, even if there's not a lot of research on them, but have used the ones that have been tested in remote environments and where there was no major statistical difference found. So just being cognizant also that any deviation from the administration guidelines of any standardized test should be noted, right? And I think one of the ways to let your client know and anyone who reads your report is if you did it through telehealth modality, you want to mention that because that is in itself already a deviation from the administration guidelines of most tests that have been normed for in person.
Is there any other specifics that we should put as disclaimers into our report? Anything else that we can kind of make note of?
Right. So, one of the disclaimers, and I'll share the ones that I personally use as I encounter the situation. You can pick and think about what works for you. I really feel that we, first of all, know on the background that equivalency of in-person administration and tele-assessments cannot be assumed, right? But validated instruments help you to identify if there is deficits in a certain area that you're examining, but your clinical acumen, your clinical judgment is what is really needed to augment the empirical findings about equivalency of the test scores. And what that means is even if a test is set out to and sensitive enough to help you identify disorders that may exist or deficits, or even just say within normal range, you still have to use your clinical judgment. And that is the final, because we are trained, right? We're trained SLPs and we have that way of making sense of all this data that those instruments give us, but they are tools. Now, one of the disclaimers that I like to use, it's my most common and go-to is this assessment was administered via telepractice modality and results should be interpreted with caution, right? There could be differences among SLPs of what was the best instrument. And so maybe sometimes you just want to say, to look at the results and really look at the whole report and see with caution, take a look and just see if you feel also that it makes sense for everything that was administered and within the time that you have. There's a lot of other factors that go into it. Another one is another disclaimer that I use is a full comprehensive assessment battery was able to be completed in one sitting with best practice guidelines followed in accordance with, and I put the developer's name and I put guidelines. Nonetheless, results should be interpreted with caution. And I seem to always say caution because the researchers also use that word, interpret with caution, right? It really does come from the data that is out there. And even they will caution you in their research, interpret with caution. It doesn't mean it's equivalent. It doesn't mean, so we're still learning even in that world, in the research world, about what works. And I hope we grow in this area. But also, if you administer portions of a subtest, you might want to state that portions of X test was administered and scores should be interpreted with caution and not overgeneralized as a full comprehensive measure of the area that was assessed.
I'm curious if you've ever gotten, questioned by parents if this was done in a private practice setting, or has insurance rejected or denied the claim because of these statements? Any comments about that?
So I personally have not had a denial that I was aware of, but I have heard that in some odd cases, my colleagues have shared with me, and they did say that the telehealth was denied, and they were asked to provide in-person services. And really, where that came from is maybe the parents' request as they communicated with their insurance about it. And maybe they shared something, or they were intending to be treated in person. And even though the disclaimers were there about we are a telehealth company and this is our way of serving you, when they communicated, it was denied. So whether one was related to the other, not sure, but I have heard that, yes, it can happen, definitely, even though it's just a modality, right? Telehealth is a modality, but you're still clinic-based, if you are providing services through this medium, or school-based, but we are not. I'm talking about insurance reimbursed clinics like mine.
Right, exactly. All right, thank you for that. So let's talk a little bit about the tools that are being used. What tools are being used and considered valid measures to administer virtual assessments?
Good question. So, in the beginning, everyone was thinking about what way to serve your client and just see and hear them, right? The basics, the fundamentals about having that face to face, which if you couldn't have, you were thinking about what's next. And it really, ASHA does do a good job of breaking it down into software based technology that is encrypted or public domains. So, if you're a university, you might be set up with a lot of hardware where you have computer terminals that serve the client and are not necessarily software based, but they are protected in ways that the client's identity or information, health information, will not be compromised. And then you have the software based technology. So, what do you contract with? Are you using Zoom for healthcare purposes? And if so, they do have what they call a BAA, which is a business associate agreement that you can sign sometimes for years, if 1, 2, 3 years, depending on the magnitude of your clinic and how you expect to see cases over telehealth. And they do have encrypted software. So this, what it does is really protect the client's information and make sure that there is measures to safeguard the client. Now, there's even more levels of security, and we don't have to go into it specifically, but then you can set up your two-factor authentication or making sure that there's just even more layers, right? But the others are public domains that have not been validated as secure and often do not indicate how much level of encrypting technology they use, like FaceTime or Skype or Google Hangouts. We just don't know. So commonly, when you think about how to serve your client and security and making sure that their health information is safe to abide by HIPAA law, you would think of a software based technology or depending on your setting, of course. But like I said, just think about the level of security, and public domains, like I had mentioned, are not the ones that we want to service through, really. And this is all meant to continue to be compliant and not violate HIPAA that can potentially place us liable for any leaks, I would say.
All right, let's talk a little bit about some of the instruments to consider for assessments.
Yes. So when I think about instruments for assessment, I think about what can facilitate what I need to do, I need to get done, but still answer the question that I have about whether this client does warrant services or not. And so you think about your instruments. My first go-to is the very traditional parent interview question format, because this is powerful. You have an open, unstructured dialogue. You can really establish rapport and get to know this client and listen to their needs. Then the next thing I think about is what tests do not require manipulatives to administer. And one of those, the PLS-5, is widely used, but they have, as an example, a lot of manipulatives that accompany this test, which there's very specific directions in which way they are supposed to be utilized to elicit independent responses from the individual rather than prompted. And so if you have a parent using a little bear and they're telling the child, there's a lot of cues, right, in the home environment. So even if you did find a way to get those to them, you can have your instrument and tools invalidated just by the way that it's prompting responses. So I steer away from that. And I feel like this has been talked about as well in the research about finding ways to assess that don't have these manipulatives unless you have a facilitator that is trained in the house of the client. So there are exceptions. I don't want to overgeneralize either. Then I look at what publishers are there and what have they done to accommodate practitioners like myself that have to administer tests in digitized formats because we don't provide in-person services for the company that we're working for. And some of these developers like WPS, Pearson, they have digitized their protocols and assessments and stimulus books, and even scoring now, right, can take place in a digital format. So I don't have much to share about each developer, but I can tell you that WPS uses an online evaluation OES platform, and Pearson uses Q Global digital assessments, where they have all of the stimulus books and just embedded, and you can use it. It's shown to the examinee in another location via the screen sharing feature. So through teleconferencing software. So you want to make sure that if you're doing these digitized assessments, you can screen share, right? And that your client has that ability to be able to use it according to the best practice guidelines. So we do our due diligence, and you have to be familiar with the various assessment types that are out there to mimic that in-person administration of these tests. And some disclaimers from the publishers too, like WPS, they have a statement on Tele-Assessments, and it reads, all, and I quote, all of our currently individually administered assessments were standardized using in-person administration. And just like I said earlier, I would say most of them were, right? For these tests, and they go on, tele-assessment methods would be considered an adaptation of the standardized administration and should be considered when reporting and interpreting the results of a remote administration. So
it's definitely important to include that in your report.
Yeah, they do. So we should.
But I did want to ask real quick before we go on. I know we don't need a fancy platform that embeds these assessments, correct? Because of course we have several out there that it does make it easier. And I know, we're both familiar with some systems that do that, and they do it each differently. But of course, the premise is similar. You're able to pull the assessment within the platform, but you don't need that necessarily. Like you said, and I heard you say this, really it's video conferencing with screen share. Of course, it's better, or it's convenient, but if you're your own private practice, or maybe you're part of a smaller practice, not sharing the content with hundreds of providers, then you could, in theory, just do it,
Yes, absolutely.
Okay.
Absolutely.
Good to know. Yeah. So let's talk a little bit about some more examples that you had of specific assessments based on ages. That'd be really helpful.
Thank you. So yes, Karine, like you said, not everyone has the ability, or even you have to have negotiated that and maybe work at a larger scale, seeing a lot of clients, to have maybe Pearson work with you and embed their assessments into your platform. So thinking on a smaller scale, if you are in private practice, like I am, and you might serve maybe a client or two over your own. And I know some clinicians do, even if they work for another company, but you still can adhere to best practice guidelines. You still can assess, absolutely. So one example of that is your traditional parent interview format. Like for early intervention, it's actually best practice because these kiddos don't necessarily have the attention or the ability to look at a screen for a 60-minute duration. And you also want to capture their skills and see how they are across environments, right? How they communicate at home, and if they go to daycare or if they go to school. You want to know as much as you can about them. So one example is the receptive expressive emergent language test. You don't have to screen share. It's up to 3 years old, commonly used, and it records parent observation of the child's behavior. You have, in a similar format, the Rossetti infant toddler language scale, up to 3 years old, where you assess pre-verbal and verbal aspects of communication and interaction in young children. And it's not just looking at one area. They really assess interaction or attachment or reciprocated interactions that the client is having with the parent or the caregiver. It looks at pragmatics, the way that the child uses language to communicate with others. But it really captures all of these skills like gesture, play, language comprehension, expression through the parent's lens and how they perceive abilities of their child. And so if you really believe that the parent is the most knowledgeable about their child, then a parent interview using these assessments that give you a way of standardizing and being still a standardized tool, right? That you does allow you to compare to other norms. Then you have your DAISY, which collects information as well. And it does it through observation, parent caregiver interview, and direct assessment, looking at cognitive communication, DAISY 2, social emotional, physical development, adaptive behavior. And I would say that for EI, early intervention, these are very much my go-tos right now in that order, literally in that order. And then we have our school aged, and if you're familiar with Q Global, you have your Goldman Bristol test of articulation, you have your Self 5, you have the TILs that we talked about earlier and used as an example. If you serve adults, it really depends also the area that you're looking at, right? But you have your E10 if you want to assess dysphagia. If you're looking at voice, you have the Voice Handicap Index, the CAPE-V. If you're looking at cognitive linguistic screener, maybe short version, the MOCA has actually a lot of research tied to telehealth, even incredible enough, but even phone administration. So looking at that, right, and seeing what they recommend to make sure you still have that instrument available and are using it in a way that could be valid through that medium. Then you have your quick aphasia battery. And this university from the quick aphasia battery, they actually have their telehealth version and they have their in-person version, and they're working on creating versions that are extended. So if you have more time on telehealth, then you get to do the telehealth QAB, the extended version. But if you have a limited time, then they have a limited time version. So I'm grateful for that. And I do get at my clinic an hour, sorry, but not everyone does. I remember when I worked in the hospital, sometimes it was 30 to 45 minutes. So times vary where you work. And then you also have your Tchaikovsky 50-word speech intelligibility test that applies to dysarthric adults as well. So I've named a few, and just ways of assessing that. You don't necessarily screen share in some of these that I mentioned, not all. Of course, you screen share in the gift and the self and all of those with stimulus. But in this list, there's quite a bunch that you just really don't necessarily have to present a stimulus on screen to conduct the assessment.
Yeah, definitely. That's good to know because it's really no different than sitting across the table from them and administering it.
Right.
Okay, so let's talk a little bit about the challenges. And I know we're going to have time for questions towards the end here, but please do continue to put your questions in the QA. What are the challenges of practicing speech language pathologists who are conducting these virtual assessments?
Yes, it's music to my ears. I face these challenges myself, and I felt like I need to find solutions and problem solve it, especially if you're telehealth. And like me initially, sometimes you feel like you don't have that coworker to consult right away, right? I can't go next door and say, what would you do? Right? So thinking about client selection, there's less options for standardized assessments for very young children, maybe between the ages of 0 to 3, regardless of modality, right? And just thinking about the client and whether they can participate and whether this session can be productive, and can I get the information that I need to make a clinical informed decision. So assessments with early intervention population frequently require the use of manipulatives, and I explained this earlier, but to ensure standardization, sometimes we have to deviate from those that you may be very used to using in person administration and consider other options that exist. And then really incorporating a parent or caregiver or the family into the assessment process to ensure spontaneous results, but at the same time, make sure that they do not prompt the child. That's a challenge, right? A lot of prompting, like they want to see them succeed. And from a parent's perspective, which I am a parent of a 6-year-old, like I think I make that mistake too. When I go to the clinics where I take him or anything like that, and they're testing him for, let's say, a school readiness assessment. And I was like talking to the psychologist, like, no, mom, no, that's not what you do. And I'm like, oh, I forgot. And I was thinking, like, in my capacity, that was me telling a parent to do that, right? And just the engagement in telepractice assessments. So how you orient the examinee or the parent to make sure that the guidelines are followed, so they and both you have the information that you need. And sometimes I explain to them, and what I share is, if you help, the results are going to be so out of range that maybe the child is not going to qualify, because it will show that they do not have a need when they do. So that really is an eye opener. They're like, oh, no, we want to make sure we capture their true skills, right? So that's one of the main ones, client selection. The other one is referral question. Why are they referring this client, and what are the reasons for this modality? So the client chose it. Some clients have shared that they even chose it because they think it meets the needs and the circumstances of their family at the moment. They can't drive so far, or the hours, and just participation, being able to be there. There are other challenges related specifically to the client. So hearing and vision, cognitive ability, and tech literacy, that's a big one. Technological literacy, like, do you know how to set yourself up for your session? And do you know how to connect your audio and your video? So I don't want to necessarily say that being a person that doesn't or has a hearing impairment disqualifies you automatically. I think we should think about technology and how it has evolved. So if you are hearing impaired, which I have served them through telehealth, what I do is, first, I need to know, what is your last hearing exam that you've had? And if you have a hearing aid, are you fitted appropriately? And your hearing aid, can it connect to your audio, right? And if so, we may have a great session and I may be able to proceed with my assessment, but making sure that those questions are asked and that you know beforehand. So one of my clients, her hearing aid stopped functioning, and we did have to put therapy on hold for some time. But obviously for the assessment experience, it was great. There was no issue there, but I was serving the deaf and hard of hearing. And I have some clients, a very specialized niche, but that I can still serve through this platform. And I was excited. Like when she told me, I have hearing aids, I'm like, do you hear me? Do you hear me? And she's like, I do. I'm connected to the audio. It's like, oh my God, this is wonderful. And the environment is another challenge. Hopefully you get to coach your client on the importance of a private space, minimal distractions. Minimal distractions also include putting the electronics far away from the child. So the phones and the gadgets and all that, right? Then you have the technology, the hardware, software that they have and that you have should be appropriate, because this is what you're set up to do. But if you're the client, do they have a large screen, a small screen? Some of my own colleagues have shared the limitations of when clients connect through their phones, right? And how it changes slightly or a lot, depending on the circumstances, the assessment experience for them. But best practice is obviously the large monitor, 15-inch, measured diagonally, your audio, and minimal environmental distractions like background noise or family snoring or laughing or dogs barking. So think about all that as you set yourself up and your client for success. And do you have screen sharing capability? Do you have the ability to annotate? So does your Zoom allow you to make selections for the assessment? In some assessments, you do have to point, like if you're doing just the gift test, sometimes you're pointing to the shoe, right? So even you as a provider, can you annotate? Can you point for your client? And ultimately, of course, the high quality video is necessary. You want to see their mouths. If you're doing an articulation exam, you want to be able to see the mouth movement, right? And making sure that even if they have this great microphone, it's not covering their mouth. So things like that are challenges, but we navigate them together. And most of the times, I would say I'm able to conduct most of my assessments.
Okay, so a question came up in my mind when you brought up the articulation, a pretty common question. So, how do you ensure that what about your oral motor exam? How would you
Right.
do that?
Yes. So I love the Beckman protocol. And obviously, I can't measure cheek strength or directly as I could when I'm touching their faces, right? So that is something that is a limitation, but it doesn't mean I can't administer an oral motor exam. So one of the things that I might do to see do they have good labial strength, right, is say, puff up your cheeks with air and hold, and we make silly faces, but the client is able to hold, and I see, were they able to hold for 5 seconds? Did they immediately go because they couldn't hold, right? That gives me an idea about strength. So even if I'm not able to touch it, but I still can see what's going on. And if I think they're being silly, I say, try it again. This time, I'm being serious. I want to see if you're strong. And, they all want to be strong. So they really give it a try until they get red. I'm like, okay, you're strong. Let it go. Does that give you an example? Yeah. And then, of course, your tongue up and tongue down and to the left and right. And are they able to do their AMRs, SMRs? So, parika, parika, parika. Now let's do it. Let's repeat it until I say stop. And I give you 5 seconds. Can you do 12 to 15 repetitions in 5 seconds? I'm hearing that. I'm seeing that. I'm looking at their oral motor differentiation skills. And I'm like, okay, this is good. They did, if it's an adult, let's say, they did 12 repetitions in 5 seconds. That's awesome. And I really can measure it. I could have an informal measure, but it's still pretty accurate. So if you're doing the Newcastle to Sarthria assessment, those are the norms you're looking at, and you're hearing and seeing that. So it's still valid. Does that answer your question?
Yes, that was very helpful. Thank you. And then let's talk about who would not be an appropriate fit, because I know you mentioned that you've been able to work with hearing impaired, but what would happen if their vision, or perhaps they're visually impaired, or there's
Right.
significant cognitive issues? At what point do we say, okay, this is not going to work, even if there are no other options?
Right.
When is, I guess, no service better than the service that you would provide?
Right. No, that's a good question. I feel that the tech part is big, and we've talked about it. If you think about, a diagnosis doesn't automatically disqualify an individual. I have asked a client, so you're visually impaired and you're not able to see the monitor very well. Have you gone to an ophthalmologist? No, I see blurry, but I haven't gone. And if they're hearing impaired and you need hearing aids, do you have them? Are they something that you can use and readily available to be connected to the audio? And do you know how to do this? So, really looking at what their tech is like, including if they have a disability, how they are up to date with their medical care, right? And educating them. So, I might say, for now, I will put your assessment on hold. And once you have this corrected and looked at, we can revisit. So definitely come back and consult this service. I really want to help you, but we have to make sure that the medical part, as needed, it's taken care of. So that's very important. And if they have the capability of mitigating that, we can revisit the assessment at a later time.
Absolutely. And I know one of the big issues in clinic based services might be because of access issues and equity of folks that all they have is a smartphone, and so
Right.
they'll show up to the assessment with a smartphone. Have you been able to conduct an assessment by phone? We frequently hear it's not best practice, but
Right.
if you're trying to navigate that fine line of providing the service and giving that access and making it equitable, what are there workarounds? What could we consider doing to make this work?
Definitely. So initially, when I was new in telepractice, I panicked. I was like, do I just stop here and say I can't help you? Because I would ask the question, do you have a backup device? No, this is all I have. But in my heart, doing the best for the client, I was like, no, I have to make this work. So I started thinking about methods or techniques where I can still get the data that I needed to make an informed clinical decision. And so I won't go into detail, but for the sake of time, but you have your parent interview, your play observation if they're little, your clinical observation in general. Then you have your chart review. So do you have a clinical report from an outside provider available to you? Then you have your language sample, that very powerful, spontaneous language as you try to elicit, and not necessarily screen sharing. I can set up a scenario, ask the parent to grab some manipulatives and talk about a topic and really look at their syntax. Did they use one word or sentences? Did they ask questions? Do they answer yes and no? Their morphology. Are they using tense markers, pronouns, right? Their vocabulary. My famous one is a 25 utterance sample if I can't do a 50, and I find it to be pretty reliable each and every time as I go back and see my initial sample, what it gave me, and then where they are now. Then you have your semantics and how they use language socially. If they are older, I might do, going back to the little ones, maybe an MLU calculation, speech intelligibility, connective speech, a phonetic inventory. So how they say their sounds and the consonant vowel syllable shapes that they have. If it's literacy based, I might do phonemic phonological awareness tests, like, can you name your letters? Can you name the sounds associated with each letter? And I might not even be showing something. I might say, A says, and I'm hoping they say, ah, and they get credit. Can you produce rhyming words? Like, what word rhymes with cat? That. Something like that, right? Your reading fluency. Get a book nearby and let's measure how many words per minute. And I later asked the parent to send me a picture to see how many words and do that count, right? Spelling. So I'm going to dictate some words for you. Can you not make an error as you're spelling your grade level words, right? And ultimately, community outreach, like what others have observed, their teacher, their doctor, their therapist.
Amazing. I was going to say, I can't believe our time is almost up. We're going to take one or two questions from the audience. And the first one, if you could just repeat the assessment you mentioned for voice earlier. Do you have that name?
Yes, I do. I did mention the Voice Handicap Index. If you want a more structured protocol, something like the LSVT is great. They have their own assessment and ways of doing this. And that's CAPE V as well. Those are some of those assessments that I use. And is it voice for dysarthria or voice in general? Because there is voice for dysarthria, and that's a little different, but then there's voice in terms of standing alone and not related to that diagnosis.
Yeah, and I believe it was voice in general.
Oh, okay.
And then one more question regarding validated assessments. ASHA has a list of validated assessments for Tele-Assessment administration. Does ASHA have a list of validated assessments for Tele-Assessment administration? Are you aware?
Right. So ASHA, what they do is they provide the research, and they do mention if you put Tele-Assessments validated, then they will pinpoint you in that direction. They don't have a list per se, but they do point you towards looking at the research about valid instruments.
All right. And I think One last important question that I wanted to ask before we wrap up was regarding emergencies, because the unexpected does happen when you least expect it, and it will happen over a telehealth session. And so, what would you do if there was an emergency during your tele-assessment session?
Yes, definitely. So, if there was an emergency, the first thing you want to know is how can I easily access my client's demographics and what are the numbers to their residing state? So, what are the numbers? So, if you dial 911 from your state, you might get your local police department, your local fire department. And that's not what you need, right? If your client is in, like myself, California. So just make sure you know the numbers to their local agencies. So if that ever happens, you know who to call right away and they could do a wellness check or mitigate any health issues that they're having as fast as possible.
And I believe one of the things to ensure that you can send that information over to the local agencies would be to verify their location, correct? Like their
Absolutely.
address.
Yes.
Yeah.
And
So that's
specifically
important.
county, what county they are in, right? And if they're in an apartment, like, do you have the code or would they be willing to provide that information to you? So it's very important to think about their
Yeah,
safety as well.
ahead of time for sure. All right. Well, this was extremely informative. And I think we have a whole lot of other questions that we'll have to answer at another possibly podcast. So thank you so much, Roxana. We truly
Thank you for
appreciate the
having me.
education and expertise you provided this evening about teleassessments in the clinic setting. And be sure to join us for our next episode in this series, episode 11, where I'll be speaking with Taina Jimenez Lopez about the topic of best practices in telesupervision. Have a great evening.
Thank you for joining us for tonight's course. To complete the course, you must log into your account and complete the quiz and the survey. If you have indicated that you're a part of the ASHA registry and entered both your ASHA number and a complete mailing address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Please note that if this information is missing, we cannot submit to ASHA on your behalf. Thanks again for joining us. We hope to see you next time. Thanks for joining us at SLP Learning Series. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe. If you like this and want to hear more, we are offering an audio course subscription special coupon code to listeners of this podcast. Type the word SLP Learn for $20 off. With hundreds of audio courses on demand and new courses released weekly, it's only $59 per year with the code. Visit speechtherapypd.com and start earning ASHA CEUs today.